Diagnosis and management of liver cancer in the era of obesity pandemic. My name is Dr. Swan Skendi. I'm Division Chief of HPP Surgery and Director of Robotic Hepatobiliary Program at Alpha Health in Tampa. Apologize that I cannot be with you in person because I have to give robotic HPP lecture in London, England. I'm happy to see that the liver symposium that I started with Dr. Muhammad in 2022 now has expanded to a DHI symposium, which this year focus on metabolic diseases. The liver cancer can come with many variety. However, for the purpose of this talk, we will focus on hepatocarcinoma, which is related from obesity. There are many causes of liver cirrhosis, which then lead to liver cancer called HCC. Hepatitis virus, Hep B and Hep C are common. Inherited disease, fatty liver disease, metabolic syndrome, related to diabetes, obesity, non-alcoholic fatty liver disease, as well as carcinogens. There are certain food, tobacco smoking, or environmental toxins can induce hepatic cirrhosis, which then lead to liver cancer development. A study had been done to see patients with high fat and cholesterol intake. They will develop intense deposition of fat globules within the liver, which then lead to steatosis, also called fatty liver. This then induces hepatic inflammation from the fatty liver that becomes steatohepatitis and eventually develops scar tissue within the liver, and at the end stage of that is called cirrhosis. Similarly, in rat that were fed with high cholesterol, high fat diet, they develop fatty deposition within the liver. Up to 30% of liver cancer are MASH, metabolic associated steatohepatitis related in the United States, with 9% of annual increase. There are 0.7 to 2.6% of HCC from MASH, which is higher than HCC from alcoholic causes. It is now the second leading cause of liver transplantation in the United States. There is a synergistic harmful impact of alcohol and metabolic dysfunction. The risk of HCC starts at F3. It means it doesn't have to be complete cirrhosis before it induces liver cancer. Even in the earlier stage, it can already induce liver cancer. We can see here development from fatty liver to a steatotic liver, metabolic associated steatohepatitis, and eventually HCC. Diagnosis and management of metabolic associated steatohepatitis is important. The patient needs to have every 6 months ultrasound as well as AFP level drawn in order to detect early cancer. The contrast-induced MRI is needed when there is a suspicious lesion on the ultrasonic evaluation. HCC is now worldwide the 5th most common cancer. There are 3 curative treatments today. One is liver transplantation. However, this must meet Milan criteria, which is very strict. Liver resection, either open or minimal invasive. And third is ablation, which is also limited by tumor size. It has to be less than 3.5 centimeters in size. Liver resection is the preferred option for patients with preferred liver function, either within child A or very early child B cirrhosis. There are many guidelines that tells us how to manage hepatocarcinoma. This is Japanese guidelines. Basically, within the Japanese guidelines, the algorithm start with division between patient that has slight moderate liver dysfunction versus severe. Patient with severe liver dysfunction, they need to undergo transplantation, or if the patient has too many tumors, then unfortunately they need to go to palliative care. The patient that has slight or moderate liver dysfunction, when they have a single tumor, then resection or ablation is best for them based on tumor size. Tumor that is more than 3.5 centimeters must be resected. Patient that has 2 or 3 lesions, they should undergo resection and ablation or even together. And the patient that has 4 more, they should be started on systemic chemotherapy and in combination with immunotherapy today. We can see here the difference of survival between patient that has surgery and without surgery. Patient with surgery live much longer than the patient who did not have surgery. Without surgery, the median survival for liver cancer is only 6 months. Therefore, resectable HCC needs to be resected. The same screen here that shows liver resection increases survival in a patient with liver cancer. There are three ways of doing liver resection: open, laparoscopic, and robotic. You can see the video clip on the right side showing technique of splitting the liver and cutting the liver cancer out. I also listed here a laparoscopic liver ablation, which we also perform in our center, and I will talk about it briefly. This is the difference between open and minimally invasive. Obviously, there's a major difference in the term of aggressiveness of the operation and the scar tissues and the conduct of the operation between the two. The end goal is the same: to cure the patient from liver cancer. Decision to perform minimally invasive hepatic section is based on the tumor size and number, and the distance between the fetal structure to the tumor, whether the patient needs major vascular reconstructions, and more important, the experience of the surgical team. 90% of liver resection at DHI in Tampa is done by minimally invasive robotic surgery in the last 10 years. This is how the specimen is removed into place in the laparoscopic endocatchback and removed out of the abdomen. More importantly, each of the specimen were sent to pathology while the patient is still in the operating room in order to make sure that the margin is clear and the patient obtained clear oncological resection. Ablation, very briefly, it is mainly used for patients who are not candidates for resection, or sometimes in addition to liver resection, to save as much as parenchyma as possible. It is only used for tumor that is less than 3 cm, because when the tumor is more than 3.5 cm, many times the recurrence is too high due to the ineffectiveness of the heat to destroy larger tumor. It has to be decided after consultation with the liver surgery team. This is the scenario where the liver ablation is used in combination with resection, meaning that the larger tumor is resected and the smaller, deep located tumor is ablated in order to save as much as parenchyma as possible. This is how the technology works. The antenna deliver heat that then kill the liver tumor. We have published many papers for the technique of hepatic resection, and we teach other surgeons how to do this nationwide. We published our experience of 530 minimally invasive robotic liver resection last year. You can see here the operative time. The blood loss in this slide is decreasing with experience and with perfection of this operation in our center. Similarly, the length of stay also decreases as we perfect this operation in the last 10 years. The outcome in terms of survival is very good, with 50 to 60% of patients are alive in 5 years. In conclusion, liver resection for liver cancer, and in this arena, metastatic tumor to the liver, bladder cancer, they all provide chance for cure with excellent 5-year overall survival for patients. Complete resection with R0 margin, meaning the tumor is removed completely with no evidence of tumor at the margin, is the standard of care in combination with systemic chemotherapy for certain tumor. For hepatocellular carcinoma, after complete resection, the patient do not need systemic chemotherapy, but for other cancer, they do need adjuvant systemic chemotherapy. Minimal invasive robotic method is superior than open surgery whenever technically visible and whenever local expertise is available. There is a need to find high volume center or surgeon with significant expertise in robotic liver surgery in order to obtain the best care, both in terms of completeness of the operation, multidisciplinary fashion of the treatment, as well as the long-term outcome of the hepatic surgery. There have been enough papers that examine superior outcome when the patient is treated by high volume surgeon versus patients who were treated by low volume center or surgeons. This is the end of my talk. Thank you very much for the opportunity to speak about the management and diagnosis of liver cancer in the era of obesity. Thank you very much.